In my presentation, I'm going to talk firstly about the differences between Takayasu arthritis and giant cell arthritis. And after that, I'm going to talk briefly about the old versus new drafted classification criteria for the large vessel vasculitis. And the main topic in here is about the temporal artery biopsy and temporal artery ultrasound, as well as the new modalities in diagnosing of the large vessel vasculitis. So both Takayasu arthritis and giant cell arthritis are systemic grammatis disease that affect the medium to large blood vessel. And in the past few decades, there was a debate if these two diseases are the same disease but have different onset. However, both of these diseases have distinct clinical, epidemiological, and response to treatment. And aortic manifestation include or involve mainly the Takayasu arthritis compared to the giant cell arthritis. And although the Takayasu arthritis initially described by an ophthalmologist with a patient who presented with a retinopathy, the ocular manifestation is mainly involved patients with giant cell arthritis compared to Takayasu arthritis. So these are the subsets of arterial involvement in both diseases. As we can see here, Takayasu arthritis involves mainly the aortic, abdominal aortic area and extends to the mesenteric and renal arteries. On the other hand, we can see two subsets. The first one for the, of course, the giant cell arthritis, which is involved mainly the subclavian and axillary arteries, while the other part is the subset for include that the aorta, as well as lesser extent to the subclavian arteries. There is also histopathological feature differences between these two diseases. We can see here the Takayasu arthritis involve the whole layers of the artery, including the intimal and medial thickening, as well as adventitial fibrous expansion. On the other hand, for the giant cell arthritis, there is only thickening of the middle layer, the intima and media, and there is no adventitial fibrous expansion. So patients with large vessel vasculitis, there is quite challenging, especially when they present with incomplete presentation. So we have to bear in mind the mimickers. For example, the neoplasia infection that we face a lot. And of course, also in the elderly patients, we can see atherosclerosis that might resemble a little bit with the imaging to the large vessel vasculitis. And of course, if patients present with cranial GCA, we need to exclude the stroke. So this is the first and the latest classification criteria for the large vessel vasculitis. And as you can see here for the GCA, it's mainly about the cranial clinical manifestation. And they only added one modality, which is the temporal artery biopsy. On the other hand, other than the the criteria for the Takayasu arthritis, they only mention about the arteriographic anatomical finding. So because of this classification criteria is an outdated and didn't mention anything about the new modality that we know as the PET scan, MRI, and temporal artery, we need a new classification criteria. And this classification criteria, the old one, didn't include the patients from the age of 40 to 50 years old, and they only included the patients from North America. So this is the new drafted classification criteria 2022 for the GCA. I'll not go through this in details. However, just I'm going to mention in few points. As we can see here, they added the using the temporal artery ultrasound. We can see here they give the same score 5 to the temporal artery ultrasound, temporal artery biopsy. But I need to emphasize that both of these are not equivalent, but they just give the same score just in case those centers have the expertise to use temporal artery ultrasound compared to those, or in other centers which prefer to use the temporal artery biopsy. And also for those patients who have the GCA large vessel vasculitis, they included using the ultrasound in the axillaries, and lastly, they using the PET scan. On the other hand, for the Takayasu arthritis, they just went in more details about the numbering of the arteries included in patients with Takayasu arthritis, and the one score for the symmetrical, and lastly, they add more scores to the involvement of the renal and mesenteric arteries. Of course, and definitely, we need to do certain investigation and imaging to exclude the mimickers and to confirm our diagnosis. So we can use one of these modalities, such as the new modalities, PET scan, ultrasound, or the old one. But the question is which ones we should use. So how do expertise diagnose the GCA? This is the DC-VAS, which is the largest international observational study for the vasculitis. They included more than 940 patients confirmed to have GCA. And we can see here in the left side that they include up to 25% of patients diagnosed with GCA did not undergo to the temporal artery biopsy. On the other hand, up to 40% of patients were diagnosed with GCA using temporal artery ultrasound. And interestingly, we can see that the European countries use the temporal artery ultrasound more than the North American. And the last one, that around 50% of other patients use different modalities for diagnosing with the large vesicle vasculitis, or GCA. So if we suspect the giant cell arteritis, which guidelines should we follow? And there's a discordance difference between the ACR and the ULR guidelines. And we can see here for the ACR, it recommends to use the temporal artery biopsy over other modalities. But when we dig more in the discussion, we can see that they also can recommend it to use the temporal artery ultrasound in these centers or have the expertise to use the temporal artery ultrasound. On the other hand, for the ULR, they recommend to use the temporal artery ultrasound plus minus the axillary arteries if there is involvement of the large vessel over the other modalities. And interestingly, the British Society for Rheumatology, they combine the clinical pretest probability in addition to the temporal artery ultrasound to determine when to pursue for the temporal artery biopsy. So in here, I've just added the most important thing that we can discuss about the temporal artery biopsy. We need to know about the timing, the site, and the size of the biopsy. So as we all know that the yield of being positive for the biopsy will be very high at the beginning or after starting the corticosteroid rather than taking a biopsy at the end. So the first study have compared those who got the biopsy before the 2 weeks. So we can see the sensitivity reduced dramatically up to more than 40 weeks after starting the corticosteroid. And on the other interesting study, which is recently, they involved the 40 GCA patients who confirmed to have giant cell arteritis based on the biopsy, and those patients were re-biopsied again between the month of 3 to 12. We can see here also there is a decrease of the sensitivity of biopsy over time. And interestingly, you can see here after 12 months of the re-biopsy, it's still positive in 40%, although these patients were in remission. So what about the site? Shall we take unilateral or bilateral? And which site exactly? So in these two studies, they included 186 patients and 250 patients who underwent bilateral temporal artery biopsy. Interestingly, they just found that around 3 to 5% of these patients had only unilateral temporal arteritis. They conclude that the yield of this increase to be positive if they take a bilateral, only 5 to 10%. And because of that, the ACR recommend to take a unilateral biopsy over a bilateral temporal artery biopsy. And definitely this would reduce the risk of arterial damage as well as the nerve damage. And also the site is important. Most of the vascular surgeons, they prefer to take a biopsy just anterior to the tragus because it's the most palpable site and the biggest part of the artery. However, there's an increased risk of facial nerve damage. And because of that, it's recommended to take from the frontal branch of the temporal artery. And also the size in here is matter. So they prefer to take the biopsy more than 1 centimeter rather than take less than 1 centimeter just to increase the yield of being positive. So definitely this biopsy needs to be interpreted. And although the biopsy is highly specific, but it's invasive and has false negative up to 61%. And not all the features or the findings might present the biopsy, such as the giant cells or lymphocytes, and also those patients who have atherosclerosis, they might have the features of the large vesicle vasculitis or giant cell arteritis, such as adventitial and periadventitial inflammation. And this study have shown they involved 14 pathologists who evaluated 30 different histopathology for patients with GCA. You can see here the disagreement among these 14 pathologists, although they evaluated the same pathology. So it's really more objective, and the question is, are we really rely only on this biopsy? So as I mentioned before, it's invasive, the temporal artery biopsy, but it also takes time in some hospitals up to 1 week, and that increases the risk of patients' exposure to the unnecessary corticosteroid. So we need an alternative for that, which is quicker, such as the temporal artery ultrasound. So for scanning temporal ultrasound, we need to scan the whole branches of the temporal artery. And as we can see here, that the longitudinal scan and transverse scan of the temporal artery. We can see the nice color Doppler of filling the whole lumen, and that's because there is no thickening of the intima and medial layers. On the other hand, as you can see on the up left side, you can see the longitudinal and transverse scan. The color Doppler is less, and you can see the hypoechoic or anechoic surrounding the color Doppler. And that's due to the thickening of the intima and medial layers. And that's what we measure exactly. So we measure the intima and medial layer for the thickness, and that's what we call the halo sign. And there is also the compression sign, which is we do a certain maneuver. We just compress on the temporal artery, and normally we can flatten the temporal artery. But if there is a patient who has a temporal arteritis, it will appear as a hypoechoic, and we cannot compress it. And interestingly, we can also use the ultrasound for patients who have GCA, large vessel vasculitis. On the upper left, you can see that the intimal media thickness is less than 1 millimeter. On the other here, in the left side, you can see it's more than 1 millimeter. And the study showed the cut-off of the measuring the temporal arteritis, or the thickness of the intermedial thickening, is the more than 1 millimeter. And for the temporal artery, it's between the 0.3 to 0.4 millimeter, depends on the branch of the artery. So what studies show about using the temporal artery ultrasound? So the 8 studies investigated the halo sign versus the clinical diagnosis of the cranial GCA. And they found that the pulse specificity reached up to 96%. And interestingly, as we know that the GCA fast-track clinics is more used mainly in European countries than other countries. And what they do, that they do the patients assessed by rheumatologists within 24 hours in addition to the temporal artery ultrasound. So the patient will be mostly evaluated immediately within 24 hours. And interestingly, all these studies show that there is a significant reduction of the irreversible vision loss compared to temporal artery biopsy, up to 25%. So is the presence of halo sign significant to the giant cell arteritis? So this study included 305 patients. All of them have halo sign. And only 14 patients of them, they have other than the giant cell arteritis. And one of these is the presence of the atherosclerosis, lymphoma, or polymyalgia rheumatica. And the false positive is only 4.6%. So, and more than that is the halo sign response quickly to the corticosteroid compared to the temporal artery compared to the biopsy. So you can see here that the sensitivity reduced dramatically within 4 hours after starting the corticosteroid. And two studies have confirmed the disappearance of the halo sign within 16 to 21 days, but not less than 7 days. So, of course, there is a lot of advantages for the using temporal artery ultrasound. One of these is it's inexpensive and it's friendly to the patients. And interestingly, you can show the patients the finding while they're lying on the bed. And the hospital admission avoids up to 89%. And definitely the downside that it needs an expertise for the rheumatologist to do that on the same day, and it needs a high equipment machine. So what other modalities that can we use other than biopsy and temporal artery ultrasound for the cranial involvement? So the EULAR recommends to use the MRI of the cranial arteries if there is no availability of the temporal artery ultrasound, or if the result of the temporal ultrasound is inconclusive. You can see here this shows the inflammation the left side of the temporal artery, and after 2 months there is total disappearance. However, we need to know that this finding or the inflammation might persist even in patients, and in one study up to, more than 50% of patients might have persistent inflammation even up to a few months. So what about using the PET scan for the cranial GCA? So EULAR recommends against use the PET-CT for the cranial GCA involvement. But interestingly, a study have shown that using a new modern equipment for the PET scan will show the inflammation, and they included 64 patients underwent PET scan after using corticosteroid 3 days, but before taking a biopsy. And the sensitivity was 92%, specificity 85%, and the negative predictive value reached up to 98%. They conclude that the PET scan for the cranial GCA might be used as a first modality of diagnosis, but we know that the PET scan is very expensive. It's not available in all hospitals. So what about the extracranial manifestation or extracranial arteries involvement? So EULAR recommends to use the MR angio for diagnosing the Takayasu arthritis patients as a first line because it has less radiation and especially because they're young. But for the GCA, large vessel vasculitis, they have no specific recommendations, so to be used either the ultrasound of the axillary arteries, MR angio, or PET scan. And meta-analysis for MR angio included or have 43 patients for 43 studies. So you can see here the specificity reached up to 88%. And the MR angio, it's better evaluation for the anatomical changes and the extent of the disease. On the other hand, for the PET scan, it's also excellent modality to use, and also the sensitivity decreased dramatically after starting the corticosteroid, and up to or more than 60% of patients in one study have shown that significant resolution of the inflammation of the arteries after 10 days of starting the corticosteroid. However, we need to know that even in some patients, it's still persistent inflammation even after months or more than that. So we cannot rely dependently on the PET scan if there is suspicious of not detecting very well, or we can use different modalities for diagnosis. And also, it might indicate a false positive for the PET scan. So this patient, 75 years old, patient who had a lung cancer, underwent for a PET scan for evaluating the metastasis. And interestingly, they found that there's a scattered of the uptake in the different arteries, but it was atherosclerosis. So to differentiate between atherosclerosis and the large vessel vasculitis, atherosclerosis is mainly scattered, but the large vessel vasculitis is mainly linear. So to conclude my presentation, both the GCA and Takayasu arthritis have different distinct features, clinical, epidemiological, and response to treatment. We can use temporal artery biopsy or temporal ultrasound, whatever the first modality available. And if this is inconclusive, then we can use either the MRI of the cranial arteries or the new modern for the PET scan. And there is a limited evidence-based guidance for the timing and the cost-effectiveness of interval imaging for evaluation. And also, imaging should not be used as a solo. Of course, we need to have full picture of the clinical manifestation. And lastly, we can combine imaging if we need that, if we are not having any conclusive for that. Thank you very much.